There is a limited window of opportunity to evaluate the patient, determine eligibility for fibrinolytics, and start the drugs. Getting that advance notice from EMS allows me to notify the stroke team so that they're poised to respond when that patient arrives.
The fourth D of stroke care is DOOR. DOOR stands for the effective triage of the patient. The initial evaluation should include assessment of the patient's ABCs, airway, breathing, and circulation. Hospital personnel should administer oxygen if the patient becomes hypoxemic while en route. It is best practice to bypass the ED and take the patient straight to the CT or MRI suite. Hospital personnel should assess a patient with a suspected stroke within 10 minutes after the patient's arrival in the ED, CT suite, or MRI suite. Follow your local protocol. Confirm IV patency and draw blood samples for blood glucose, electrolyte, CBC, and coagulation studies. Even though EMS did a fingerstick blood glucose analysis, hospital personnel should review and verify blood glucose results. Hospital personnel should also acquire a 12-lead ECG, which may identify a recent myocardial infarction or arrhythmia as a potential cause of the stroke. The next step in the 8 Ds of stroke care involves the collection of data, ideally within the first 20 minutes of a suspected stroke patient's arrival.
I get her history, perform a general physical examination, a neurologic examination, and establish a time of symptom onset. In this case, the first symptoms were about 45 minutes before. After asking a few questions and performing the NIH stroke scale, there were pretty clear indicators of a stroke. Since EMS had called ahead on their way to us, we already had our neurologist standing by.
Now, you have to remember the clock is ticking, so that means that you must evaluate the scan immediately. Now, our benchmark is that should happen within 45 minutes of the patient's arrival. The CT scan will help me determine if an intracranial hemorrhage is present. Now, if a hemorrhage is present, then our stroke team is going to pursue an entirely different path of treatment. On the other hand, if I find a normal CT scan, as in this case, that suggests an acute ischemic stroke is causing the patient's symptoms.
That brings us to the final link in the stroke chain of survival: rapid diagnosis and treatment in a hospital equipped for acute stroke patients. This is also the 6th D in stroke care: decision regarding treatment. In addition to IV fibrinolytics, endovascular therapy is recommended for large vessel occlusion, or LVO, patients who meet inclusion and time criterion. In some cases, endovascular procedures may not be available. An interfacility transfer should take place for those that meet the criteria for endovascular therapy.
With an ischemic stroke, CT scans often look normal within the first few hours of symptom onset. In this case, the CT scan looked normal and there was no evidence of bleeding. Thankfully, we were well within the window of fibrinolytic therapy. But before I recommended that treatment, I performed another neurologic exam and I asked some questions that were part of the fibrinolytic checklist. The neurologic exam showed no improvement. But before recommending fibrinolytic therapy, I wanted to review the patient's records and to see if there was any pre-existing conditions that might interfere with the drug treatment. These include brain hemorrhage, prior stroke, abnormal blood vessels in the brain, recent bleeding anywhere, any history of blood clotting problems, recent surgery or accidents, or certain prescription medications. Now, I wasn't seeing any potential problems with the drug therapy. Nancy, what's her current BP?
It's 192/114.
Okay, your blood pressure's still a little bit high, so we're going to give you a drug to help bring that down, okay? Okay, let's give her 10 milligrams of labetalol and try to get her systolic blood pressure down to 185 and her diastolic down to 110. Now we'll recheck in about 3 to 5 minutes. If it's still elevated, then we need to double it or consider an IV infusion. Let's don't waste time here.
Okay, right away.
Okay, that's right.
If the patient's medical history is acceptable, if the time of onset is generally less than 3 hours, and if the patient's current condition can be managed within suitable parameters, it's time to move to the next D of stroke care: drug and/or device.
Mrs. Vega, we'd like to recommend a medication to you that may break up the blood clot that's causing the stroke. But we'd like to talk to you about the potential risks of this medication so you can make an informed decision.
What kind of risks?
There is a small possibility of having a cerebral hemorrhage. that's bleeding into the brain. Now, if this occurs, Mrs. Vega's situation could get worse or may even possibly be fatal.
Well, it's only a very small risk, actually, about 5%.
That's right, but you still need to consider it. Now, the upside to this is the drug treatment may break up the blood clot in the brain, potentially restoring or improving blood flow to the affected areas, and that's a good thing.
Studies show that the drug therapy can improve the chances of recovery by 30% if administered within the first 3 hours of the symptom onset.
Now, the window can be extended for some select patients to 4.5 hours, but Mrs. Vega will easily make the 3-hour window, and that's even better.
That number works for me. Sounds like it's worth the risk. Honey?
Okay. Nancy, based on her weight, let's administer our TPA according to our protocol.
Will do.
Okay, it's going to take us about an hour to give this medication to you through your IV.
I would do blood pressure and neuro checks every 15 minutes while she's taking the therapy. I'd also monitor her neurologic status.
Good. Looks like you're in good hands. I'll check back with you after the therapy.